morning and welcome to Medicine Grand Rounds. Vince Crines is going to be providing introductions. I just wanted to cue things up and actually acknowledge Vince. This Science Now series of having just high impact, shorter presentations was really his brainchild. This is his third year of really successfully leading this program, giving an opportunity for our audience to see the great science that's going on and giving an opportunity for our scientists to present. So I just wanted to kind of take the stage before Vince takes over and just acknowledge him publicly for really setting up a wonderful series. And thanks to you, Vince.
Thanks, Rick. Welcome to Science Now. Today's theme is clinical investigation, inspired often by a patient encounter or one of those many challenging, impossible to answer questions we get from our trainees all the time. So everyone in the audience really has a chance to make a contribution here. And physicians, clinicians, bedside observation has never been more important. So with that in the way of background, we have two great speakers. Our first one, Karen Hansen, is an associate professor in the Division of Rheumatology. She is a world expert on vitamin D metabolism. She told me today that her recent paper was highlighted in New England Journal of Medicine Watch. This is a paper that was published in JAMA Internal Medicine. Did I get that right, Karen?
Yep.
Okay. So Karen will be our first speaker. She'll have 25 minutes and then some time for questions. And then no less Sterling will be Sterling Johnson following her. He is a professor in the Division of Geriatrics who's using neuroimaging as a biomarker to identify patients with early Alzheimer's disease. And of course, this is the key to potentially intervening at a time when the disease is treatable. So with that, I won't introduce you, Sterling. You'll just kind of seamlessly show up on stage.
Well, thank you very much for allowing me to share a study that we just got published in the past year. And really, we'll be talking briefly about how vitamin D affects our pathophysiology, and then talking about optimal vitamin D intake based on different experts, and then the clinical trial results. So you might recall that when we are deficient in vitamin D or we have low calcium intake, we have a drop in the intestinal calcium absorption, which triggers a drop in the serum ionized calcium. And then our parathyroid glands are exquisitely sensitized to this, release the hormone from the glands, and this upregulates the osteoclast to release calcium from our skeleton, and also to trigger renal synthesis of 1,25-dihydroxyvitamin D, which is calcitriol. And all of this helps to raise the calcium levels back in the body. However, ongoing high PTH can lead to loss of calcium from the skeleton, presenting as osteoporosis or osteomalacia. So there's a lot of debate about the optimal vitamin D level for skeletal health, and the Endocrine Society published a paper saying they felt 30 nanograms and higher was optimal, whereas the Institute of Medicine was saying 20 nanograms and higher is optimal. And the U.S. Preventive Task Force looked at the data a little differently and said, well, we don't really see that vitamin D by itself reduces fractures, so we don't think you should bother taking it. Now, the Endocrine Society was saying, take a lot of vitamin D, take up to 4,000 IU a day. And the Institute of Medicine looked at the literature and said, well, optimal levels are 20 nanograms and higher, and we can achieve those levels by taking 600 to 800 international units of vitamin D a day. And really it's 600 IU for everyone between the ages of 1 and 70, and then once you hit age 70, to increase to 800 IU a day. Well, why was this disagreement possible? Because few subjects recruited patients based on their initial serum vitamin D levels, and then even fewer targeted a certain vitamin D level with their intervention. And most of the clinical trials co-administered calcium with vitamin D, so sorting out the benefits of vitamin D by itself became a challenge. So in a pilot study here at UW, what I did is recruit postmenopausal women who were healthy but had vitamin D, quote, insufficiency, that is a vitamin D level less than 30 nanograms. And I measured their intestinal calcium absorption at baseline in this, quote, insufficient state. And what we do to measure calcium absorption is to administer 2 stable calcium isotopes, one intravenous and one oral. And this carefully tracks calcium through the body. And then we measure the calcium that comes out in the urine. And we can calculate the intestinal calcium absorption, and this is a gold standard technique. And so we basically had a baseline measurement, and then they received a high-dose vitamin D regimen that raised their vitamin D levels to above 60 nanograms. And at that point, we remeasured their intestinal calcium absorption, and it increased about 3%, which was statistically significant. So it seemed that raising vitamin D levels might lead to more favorable calcium balance, which would then translate into improved skeletal health. So we got funding for an NIH clinical trial, and what we did is we recruited postmenopausal healthy women with a vitamin D level officially in the insufficient range, less than 30 nanograms, randomized them to 1 year of 3 different treatment arms. So the treatment arms were placebo, low-dose vitamin D, which I chose to be the 800 IU, and then the high-dose vitamin D, which I'll explain in a moment. And our study outcomes were the change in intestinal calcium absorption as the primary outcome using that gold standard method. And what we do is we actually admit people to the clinical research unit. That's a great resource here for us to use and they're fabulous. And they basically will admit people in the morning, give them the isotopes, and then every drop of urine is collected over the next 24 hours to really get an accurate measure of that calcium absorption. Secondary outcomes were bone density at the spine, the hip, and the total body. And then our third outcomes were muscle function tests, so timed up and go test, 5 sit-to-stand test, a muscle mass measurement by whole body bone density, and then falls. So to be eligible for the study, subjects had to have a vitamin D level less than 30 nanograms and be at least 5 years past menopause because of the rapid drop in bone density that occurs at the time of menopause, especially for postmenopausal white women. If they had had hysterectomy, they needed to be at least 60 years of age. And there's some evidence that as we become older, we may be resistant to the beneficial effects of vitamin D on calcium absorption in our gut. So we excluded women who were 76 years of age and older. In terms of excluding women from the study, we wanted to make sure that we didn't harm our patients with high-dose vitamin D. So we excluded people with hypercalcemia or kidney stones. We wanted to make sure that we would have no people with osteoporosis in the study, because if they were randomized to placebo, I don't think that would be an optimal treatment for them. So if they had osteoporosis by bone density or a fracture, we asked them to not participate. And then we excluded diabetics because they have a unique skeletal phenotype with cortical porosity, and that's hopefully going to be another research study. And we excluded people with active cancer within the past 5 years, excluding skin cancer, anyone who might not absorb calcium because of an underlying GI illness, anyone with impaired kidney function so that they couldn't convert vitamin D to its bioactive form. And then, of course, women taking vitamin D at a dose of more than 400 IU a day because they generally wouldn't be eligible for the study. So in terms of our sample size, we aim to recruit 70 subjects per arm, which would give us 90% power to detect a 3% change in calcium absorption between the high-dose arm and the placebo arm, and a decent power to detect a difference between the high and the low-dose vitamin D arm. And then when we had data from the trial, we analyzed using ANOVA or a skewed test for skewed data. with a correction to control for the multiple p-values, the Benjamini-Hochberg method, because we had more than 100 p-values, probably closer to 300 p-values in the study. So this paper was published last October in JAMA Internal Medicine, and here are the results. So in terms of recruitment, we had community flyers and newspaper ads, and we had an outpouring of over 2,500 people who called into our research center, and many of those were excluded at the phone screen because often they were taking vitamin D at too high of a dose or a prohibited medication, or they ended up really not being interested in the study. A small number we weren't able to reach. And then we had a face-to-face screening visit with almost 900 women. And at the first screening visit, most of these were excluded because their vitamin D levels were outside the range, most often too high. If they were eligible based on vitamin D levels and other labs, we then brought them in for a second screening visit where we measured bone density. And a number of those people did have osteoporosis and were excluded. And then at that visit, some people decided they really would not want to take placebo or be in the trial, and they also departed. So that left us with 230 eligible women who were randomized into the trial. So this is just a schema of what happened. So I'm very delighted to report that only 4% of women withdrew from the trial, which is an astoundingly low number. And then in terms of those who did complete, we had very small numbers of people where we couldn't analyze the primary or the third outcome. Everyone had bone density data to analyze. So because high calcium intake may allow adequate passive calcium absorption from the gut that doesn't require vitamin D-mediated translocation across the cell, we wanted to make sure that people with high calcium intake were equally stratified into the three arms, and our Pharmacy Research Center did that for us. And we also stratified by hyperparathyroidism, which happened in less than 10% of the people who were in this trial. So again, to preserve blinding, the placebo arm took a daily white placebo and intermittent yellow placebo. Low-dose vitamin D arm took a daily vitamin D capsule of 300 IU a day and intermittent yellow placebos. And then the high-dose vitamin D arm took a daily white placebo and intermittent high-dose vitamin D capsules. Because we wanted to make sure that high-dose vitamin D arm had their serum level over 30 nanograms for the whole year, Pharmacy looked at vitamin D levels at every study visit, and for any subject who dropped below 30 nanograms in the high-dose arm, there was a redosing regimen and then a higher maintenance dose. And then, of course, that could unblind everyone, so we had sham adjustments of the yellow placebo capsules in the other two arms. So in terms of the high-dose regimen, what we did is just the same regimen that I used in the pilot study, which is a 50,000 IU tablet once a day for 15 days, what I call a loading dose. And then the maintenance dose was 1 pill every 15th day for 1 year. So how would you keep track of that every 15th day? With a pill box. So we had these pill boxes that we used throughout the study, and I think this was a major strength of the study because it promoted fabulous adherence. So we would just mark the days of the Mondays so people would be oriented to which day they should be opening their little box. And then we marked the yellow days to make sure those were taken. Now, if somebody dropped a yellow capsule down the toilet or the sink, they could just get an extra pill from here. So, and we did pill counts at every study visit. And then at the end of the trial, this is our adherence, and it's a median and interquartile range. And you see it's close to 100% or 100% with no difference across the treatment arms. So we had fabulous adherence to the study regimen. So now, looking at the baseline characteristics of the women who participated in the study, they were well matched for age, weight, race, and bone density across the three treatment arms. They were also well matched for their dietary habits, and in particular, their dietary calcium and their supplemental calcium. So that was important in particular. And then baseline laboratory studies were also well matched across treatment arms. So in particular, the vitamin D level, which I'll show you on a graphical slide in the next minute, but parathyroid hormone, kidney function, estradiol, and calcitriol levels. Okay, so here is what happened with vitamin D levels during the trial. So what we see is starting right around 21 nanograms at screening, 20 nanograms at randomization, and then the high-dose vitamin D arm goes up to about 80 nanograms at 30 days, and then keeps nicely above that 30 nanogram magical cut point, which is right here, throughout the trial. And then the low-dose vitamin D arm going up a little bit, and then the placebo arm maybe dipping a little bit. And the p-values for these differences were significant across the trial, except for the differences between arms were not significant at screening and at randomization. So really getting to the meat of the matter, this is the data on the baseline and the 1-year intestinal calcium absorption by treatment assignment. And in the placebo arm, there was a little dip in calcium absorption. In the low-dose arm, there was a larger dip. And in the high-dose arm, a small increment in calcium absorption. Just by chance, the placebo or the low-dose arm had a little bit higher baseline intestinal calcium absorption. So when we looked at the data controlling for the baseline calcium absorption values, we saw a little bit more pronounced benefit of vitamin D at the high-dose arm, a 1% increase in calcium absorption. And that was significant compared to low-dose and compared to placebo. And the differences between placebo and low-dose were not statistically significant. So, and of course we had women fill out these pretty onerous diet diaries. I don't know how often you've ever written down everything you ate for up to 1 week at a time, but it's a lot of work, and this was the least favorite task of anyone in the clinical trial. But they were gracious to do this for us, and at baseline and 1 year, we looked at the changes in dietary habits and really saw no difference across the year, and especially no difference in the calcium intake. So now the secondary outcome is bone density, and the bottom line is, after looking at the false positive discovery rate and adjusting for that, we found no significant between-arm differences for the changes in bone density at any skeletal site. So drilling down to the more nitty-gritty details, this is the data for change in calcium absorption, and there's no difference across, this is the data for the change in spine bone density, and no difference across treatment arms. This is the difference for total hip bone density, and again, no difference across treatment arms. Femoral neck bone density was initially exciting with a p-value that was significant, but then with the adjustment of the hundreds of p-values in the study, no significant difference, and no signal for the change in total body bone density. Now moving forward to the muscle outcomes, I'll just kind of quickly summarize those. Nothing significant. So, sorry. So really, the timed up and go test, the 5 sit to stand test, the muscle mass, the falls, and the number of people who fell, no difference. Well, in terms of safety, there was a little signal about urine calcium levels, and this is the analysis of variance. When we did the pairwise comparisons, really it was the high-dose arm where we saw, this is reporting kind of a negative, so placebo had lower serum calcium, lower urine calcium at 60, 120, and 1 year time points. And there was a little signal at the 60 days for higher urine calcium in the high dose compared to the low dose. But if we look at the clinical relevance of this, it really didn't pan out. So frank hypercalcemia, only 2 patients in the low-dose vitamin D arm had that, and no significance across the treatment assignments. Hypercalciuria, more common in the high-dose vitamin D arm, but statistically not significant. And then the kidney stone event was in one patient in the low-dose arm who had a CAT scan of her abdomen for another reason than flank pain or hematuria. And they incidentally found a kidney stone during that CAT scan. And we said, well, we went back in her medical records to see if she'd ever had any imaging before. And she hadn't, so we really didn't know the timing of that kidney stone. Again, we already went through falls. No difference in fractures, infections, hospitalization, and there were no deaths in the study. So, in summary, we found that correction of vitamin D insufficiency, defined as a vitamin D level less than 30 nanograms, with a high-dose vitamin D arm, led to a small rise in intestinal calcium absorption. However, no significant effects on bone density, functional tests of muscles, muscle mass, falls, or the number of people who fell. So really going back to this statement by various experts, the Endocrine Society saying take a whole bunch of vitamin D, the IOMs saying take a little bit, and we have a recommended daily allowance, and the U.S. Preventive Task Force don't bother taking vitamin D because it doesn't reduce fracture. Really, our study recruited people with baseline vitamin D levels of about 20 nanograms, and that's where the Institute of Medicine said we were vitamin D replete. So if we think about an approach to the requirement for a nutrient, really it's determined at the point at which a further increase in that nutrient doesn't benefit our body. And so our trial really supports the Institute of Medicine conclusion that people are vitamin D replete when their serum level is 20 nanograms and higher. Now I have a couple seconds to share with you another report that echoes what I just told you. And I just want to highlight this less is more comment. And I thought this was really interesting that the authors of this paper had been key in promoting the concept that a vitamin D level of 30 nanograms and higher is the very best thing we can do for our bodies in terms of muscle and bone. So what these authors did is they recruited 200 ambulatory adults, 70 years of age and older with a prior fall in the past year, and randomized them to one of three treatment arms, 4,000 IU vitamin D once a month, 60,000 IU once a month, or another similar regimen that got pretty close to the higher dose. And the outcomes were the short physical performance battery, which is a composite score of walking speed, chair stands, and tests of balance. And then, of course, falls, and they used a gold standard monthly diary to track these. So what you can see is that throughout the trial, everybody had an improvement in their physical performance across the trial, with no significant difference between the treatment arms for that improvement. But here's the concern here, that there were more falls in the high-dose, the two high-dose arms compared to the low-dose. Now, the next thing I want you to focus on is they did a post hoc analysis and said, well, what about the achieved vitamin D level during the trial? So let's divide the data into quartiles and just compare the hazards of falling across those quartiles. And seniors reaching the highest quartile of vitamin D, which was the 45 to 99 nanogram range at 12 months, had almost a 6-fold increased risk of falling compared to those in the lowest quartile. And I want to note that this is where we define, by the Institute of Medicine, 20 nanograms and higher indicates vitamin D repletion. So I really think that these two trials support a moment in time where we can update our UW laboratory reports to say that vitamin D levels 20 nanograms and higher are optimal. Right now, when you order a vitamin D level, you're going to get a yellow flag if the vitamin D level is less than 30 nanograms, and you would be perhaps compelled to use vitamin D to treat that, quote, abnormal level. So I want to thank my participants especially, and I think one of them is here with us today hearing this trial. And I want to thank a whole bunch of other people who made the study possible. As you can imagine, it was a Herculean effort. Clinical Research Unit, the Research Pharmacy, Weissman Center, State Lab of Hygiene analyzed the calcium isotope levels in urine, Primate Center, UW Lab, Binkley's DEXA unit, and a whole bunch of people who were there for all of the study visits and supported the funding of the trial. Thank you. Yeah, repeat the question. I'll take any questions. Yes. So Dr. Fagan's saying you're talking about the second trial. Was it coincidence that the high-dose vitamin D arm had a higher risk of falling? I mean, it was a placebo-controlled trial, so why would it be coincidence? I mean, basically they said in the low-dose arm, that was the lowest risk of falling, and then when they did the post-hoc analysis, it was the vitamin D levels in the lowest quartile that had the fewest falls. So I think the question you might have implied by your first question is what would be the mechanism by which high-dose vitamin D increases the risk of falling? And that I don't have a good answer for. Yes, question there?
Are individuals with a vitamin D level of less than 20 more likely to get hospitalized than those with a higher vitamin D level?
So are individuals with a vitamin D level less than 20 nanograms more likely to have osteoporosis than people with a higher vitamin D level? The answer is yes, and those cross-sectional epidemiologic studies have really driven a lot of the conclusions about higher vitamin D levels being better. Yes?
I wanted to say that there was a recent trial in Rheumatology that showed that calcium supplementation might accelerate cerebrovascular disease and increase here. So it's possible that a high dose vitamin D in that trial, it might be affecting their cerebrovascular changes and cause falls.
Okay, so Dr. Gallagher, I'm just going to repeat what you said so everyone can appreciate. A recent trial with calcium supplementation finding that it promoted cerebrovascular disease, and now you're wondering if that might be an effect in the high-dose vitamin D arm in the Falls trial, that maybe there was some central neurologic effect of high-dose vitamin D on risk of falling. Question there?
Okay, I'd just like to say thanks for sharing such an elegant study. This is so impressive, and really it goes to show this is so pertinent to us as clinicians every day. I address this every day as a general medicine physician, so this will really help me to take better care of my patients. Thank you very much.
Thanks, Dr. Trowbridge. Okay, I don't see any. Oh, one more hand.
In that one slide where you showed that the p-value that was significant, but then you adjusted it more than significant.
Right.
Does that suggest to me that possibly the study maybe not be powered to show the value?
So that is a good point. I mean, are we saying that high-dose vitamin D really didn't show significant benefits because it wasn't a long enough trial? And I would say maybe, but I guess I would go back to the U.S. Preventive Task Force synthesis of the data and say, well, I mean, are we reducing fractures overall with vitamin D? And they actually have found that it doesn't reduce fractures. So, I mean, I think my trial was really designed to look at calcium absorption. We saw a small change, but that 1% change would be the same thing that you could get from just consuming an extra serving of dairy per day. So, but I think your point is well taken. You know, if we had, the trial cost $3.2 million. So I would have been happy to do it for a longer period of time, but that wasn't something we had the money for.
Good morning, everybody. It's great to be here. I'm excited to tell you about our work in preclinical Alzheimer's disease. And the title of my talk, Who Will Get Alzheimer's Disease, is something I hope that you're not expecting an answer to today. That was just to get you here. We're working on it, and we think we do have made some progress, and I'll tell you a little bit about that today. We can think of preclinical Alzheimer's disease as occurring in stages, and I think something that you'll see in my brief update today is that many of the things that we measure in Alzheimer's disease and the things we talk about in labels or categories are actually very much stages of a continuum underneath, and you'll see some of that. So just first things first, a little bit of background. Dementia, often our patients say, what's the difference between dementia and Alzheimer's disease? And you most likely tell them that dementia is the behavioral syndrome that is the change that we experience, and Alzheimer's disease is one of many causes of dementia. And Alzheimer's disease can occur beginning in midlife, but it doesn't express itself in symptoms till much later. And here's a list of some other causes of dementia. Vascular disease is the next biggest cause. Something called Lewy body disease is another type of neurodegeneration with inclusions in the cell body. And there's combinations of these things, and then several more rare causes of dementia that we would rule out in the clinic. So this is an important issue, of course, because 5.4 million in the U.S. have the dementia stage of Alzheimer's. We project that 14 million will have it by 2050. At the current rates, it's the sixth leading cause of death, $200 billion in annual costs, and no effective treatment. In Wisconsin, 110,000 people have dementia due to AD right now. That's the estimate. And about 700 million in annual Medicaid dollars in our state are devoted to care of Alzheimer's disease and related dementias. So if we could lower or delay the risk of, or delay the onset of this disease, it would potentially translate into a 75% reduction in the number of cases. And that would, of course, alleviate that financial burden on the states and the nation, and perhaps give us the resources to find an even better cure. So we do need an effective treatment. That's a major problem with this disease right now. The current treatments are symptomatic, and they're not disease-altering types of treatments. And so the problem is how to identify the disease in the absence of symptoms. If we do believe, which we do, that the symptoms begin 10 to 20, or the disease begins 10 to 20 years before the symptoms emerge. The approach that the field has taken in the past has been looking at risk factors, things like age, parental history of AD, risk genes like the ApoE gene, apolipoprotein E, and there's several alleles of that. The E4 allele is the risk allele. There's other genes. There's actually about 23 that have been identified, but ApoE is by far and away the gene that accounts for about 90% of the variance in the genetic contribution to AD. Women have the disease twice as often as men do, and there may be several reasons for that, including a survival bias. There's also an effect of one's lifestyle and health that may confer risk and resilience, and if I have time, I'll touch on that. So those are some ways of assessing, maybe stacking the deck of studying this disease, but it would be much better if we could study the actual disease itself, and there are now ways of doing that with positron emission tomography scans, PET scans. We can also look for the major culprits of Alzheimer's, amyloid plaque and tau in the spinal fluid. There's also an intriguing correlation with vascular pathology that may be more interactive than we think, rather than just co-occurring, and there may be some synergy between those kinds of pathologies that I'll touch on here in a second. So here's a conceptual framework for Alzheimer's disease. You can see Here in the shaded area is the symptomatic stage, mild cognitive impairment, and the dementia stage. And it's kind of a broad band because there's people who may be at high risk and have low resilience, and people with lower risk who have a healthier lifestyle. So there's some uncertainty here. But these lines here are the biomarkers, and one of these is amyloid, and one of them is neurofibrillary tangles, and I'll show you a little bit more about that in a second. So these things are occurring very early, we think many years early. And so if we can identify people with these changes, those are the people we'd want to put in clinical trials. Those are the people that we'd want to, when we have effective treatments, do some preventative therapy with. And also the kinds of people we'd want to study to see who is resilient and what are the features, whether it's lifestyle or genetic features, that make one resilient to the symptoms when you do have the disease. So we talked about stages. This is the first staging scheme that I alluded to, and this is in the preclinical framework. We've got a stage 1 where you've got amyloid, one of the major protein depositions in Alzheimer's, and stage 2 where you have amyloid and tau-related pathology, neurofibrillary tangles is what that is, and a stage 3 where you've got those things plus a little bit of cognitive decline, and then eventually that transitions to the more symptomatic phases, MCI and dementia. There's another staging system. I don't know if you can see that, but this is in 2016 published in our main journal in Alzheimer's disease, and they say that there's no reason why amyloid should be primary. If you have amyloid or tau, you are at risk for the disease, and if you have both, then you have the defining features and you have preclinical AD if you don't have symptoms, and if you have symptoms, you have symptomatic Alzheimer's disease. So what is this disease? These are the plaques and tangles I was talking about. These plaques occur outside the cells and outside of the neurons, whereas the neurofibrillary tangles occur inside of the neurons, and they can spread. And this is from the hippocampus, and this is from a piece of cortex in the brain. And we can now image these things with these kinds of PET scans. They're fuzzy-looking images, and they're overlaid on top of the MRI here. But you can see these red areas, and these are areas where there's amyloid plaque in this case. And over here, the red means more signal again, and we can see this occurring in the temporal lobes mainly, and some off-target binding in the basal ganglia. This is what the neuropathologist sees for the tau pathology, the neurofibrillary tangles, and they have their own staging system because their pathology, this tau pathology, occurs on a continuum as well. So here's their stage 1, and actually this is stage 1, this is stage 2. This is an individual who on this side is stage 2. It's just in the hippocampus and related regions, entorhinal cortex. And on this side of the brain, they're in stage 4 because that pathology is spread all the way to the middle temporal gyrus. And they have particular criteria for the amount of spread in their staging system. Here's somebody in stage 3, an intermediate stage, where the pathology has stopped spreading at the fusiform gyrus. And then here's somebody in stage 6, the most advanced stage in this scheme, and they have, it's all over the brain. It's everywhere in the cortex. So that gives you an idea that this disease isn't just a binary on and off, present or absent. It occurs in very much in a continuum. And that's illustrated here from those same authors, Brock, who is in Germany and has been the world-leading pathologist on this disease. From over 2,000 cases in a brain bank, just pay attention to the bluer areas and ignore these purple areas. We're talking about stage 1 and 2, stage 3 and 4 in the dark blue, and what we would think is the pathologic stage 5 and 6 in the black down here. And these are ages here. And across these 2,000 people, this is the percentage of people that they saw these different stages in. And if you just look at stage 1 and 2, and you look at this column at 60 years of age, nearly 80% of people show that subtle tau-related change. And if you're lucky enough to live to 100, everybody is going to have some of that pathology. Look at the more advanced stages, though. These are much more rare, and these are the symptomatic cases of Alzheimer's disease, one would think. And about 20% of people have that kind of pathology. The same is true for the amyloid pathology, although it doesn't have quite as much of an age-related effect as the tau pathology does. Stage 4 is the most symptomatic in this amyloid scheme, and stage 3 is also signifies advanced disease. And by 60 years of age, maybe 10% of people have that in their brain. So that's how the neuropathologist sees it. Whether we can translate what we see on imaging to that kind of thinking is something that we're working on now. This is something that's not just unique to us. There's probably a couple of dozen places around the country that can do this kind of imaging. We're lucky enough to have the resources in radiology and medical physics to be able to do this here. But there's several tracers that one could look at to study amyloid, and there's several tracers, PET tracers, that you could look at to study tau. They differ in their quality and their off-target binding and a bunch of technical details. But we're using one called C11PIB. It's carbon 11, which means a very short half-life. You've got to get it in, and the stars have to align, and we have to make it and get it into the patient within a very short amount of time. And then the other one is we're using this one called F18 THK5351, which we get from Tohoku University. This one, by the way, we get from Pittsburgh University. This one is F18, like most of these here. F18 has a much longer half-life. You can take your time with it. In fact, you could probably order it from a central distribution site once this becomes clinically available, and get it here like we do with FDG for many of our cancer imaging and brain imaging. So those kinds of things are down the road. We're here looking at this mainly for research. Let me just show you a couple of cases real quick. The top case is somebody who had an amyloid scan here on the left, and here's their MRI, and here's their neurofibrillary tangle scan, their tau scan. This is a 70-year-old who's normal, but has been showing some decline because we've been observing this person over many, many years, about 10 years. And here's a case that's similar in age, a 71-year-old female here, and here's their amyloid scan and their MR and tau scan. And you can see very similar effects in these two individuals, but one of them is symptomatic and the other is still very much normal. What is it about these people that makes one person susceptible to disease and one person able to function normally? Those are important questions that we're trying to figure an answer to. It may be that first case, we would call this first case, as the one on top, as somebody who has Alzheimer's disease. They just don't have the symptoms yet. So here's another couple of cases. These are in this intermediate zone, the MCI, mild cognitive impairment phase of the disease. At least we thought so when we saw them in the clinic. I'll use the pointer here. This first case is an 85-year-old male. His mini mental or MoCA score is 24, which is kind of consistent with a subtle impairment. And he has got poor recollection for stories and kind of the standard neuropsych tests we would do in the clinic. Looking at his images, though, we see here's the amyloid and here's the tangle images, plaques and tangles. Very little amyloid. It's mostly in the white matter. It's off-target binding. And he has also not a lot of convincing tau for somebody of that age and level of symptoms. So this person may not have Alzheimer's disease. Their cognitive dysfunction is probably due to something else. In this case, we see a little more evidence of amyloid pathology. And on the tau scan, we see this nice ribbon of tangle pathology showing up in the ventral temporal lobe, characteristic and reminiscent of what the pathologist would see. And so this person likely does have Alzheimer's disease. So this is an instance where this kind of imaging might help us make a more accurate diagnosis. And there's currently a national study going on to look at amyloid imaging, at least, in the clinical setting to see if that helps us make a more accurate diagnosis and if it helps us with our treatment planning. Just wanted to show you another, I mentioned there were several tracers for tau. Here's another tracer. It's called T807, and you can see the different properties. These color maps are kind of arbitrary. It's whatever we think shows off the pathology the best. In their case, they put this kind of color map on it, but you can see that in their dementia case, who was age 52 and had a mini-mental of 11, it's very advanced, there's pathology around the cortex, but these other less advanced cases show pathology in the medial and ventral temporal lobe. So these different tracers are showing very much the same thing. Here's just a couple of, or 7 cases from our series here, and just pay attention to the top row and this top row, this coronal set, and this row here. These are 7 different patients, and it goes from most normal 53-year-old cognitively stable female to a 74-year-old patient with AD. And if you look here at this top row, here's somebody who looks like they're positive for their tau scan. It's a 74-year-old female who's shown some subtle decline over the past several years. And if we go down to this person's amyloid scan, that's these 2 rows on the bottom, this person also has a great deal of amyloid in their brain. Again, this person likely does have Alzheimer's disease, and the question is, will they go on to get symptoms, and when will they go on, and what can we do about it? A couple of other cases, this 70-year-old female who's cognitively stable also shows signs of tau and amyloid in their brain, very much consistent with this case of dementia over here. So we're just getting started with this. We do have some NIH funding to get going in a major way with this now, and I'll mention that in just a second. Just in the first 17 or 18 cases that we've done, we've parsed this like the pathologist would with Brock staging, and everywhere where you see pink here is where there's positivity for tau, and the columns are the different Brock stages for tau. And we can see that there are cases where, actually, let's just start here in the beginning phases. Everyone's got it in our study, nearly everyone. And then as we go to more advanced stages of disease, we see less tau pathology, very much consistent with the neuropathology literature. And this final column are the amyloid scores. And what we're seeing is that as you advance in your tau pathology, you're also more likely to be expressing amyloid pathology. And in fact, we have good agreement. The update of these numbers here continue to show good agreement. Here I've reported 6 of 7 amyloid cases were also advanced in their tau staging. And 7 of 9 people who had a stage 4 tau or more were also amyloid positive. So reasonably good agreement, and we continue to see moderately strong associations with cognition. So that's an important advance, I think, for the field. There'll be much more to come on this. I want to talk for a minute about the interplay with vascular pathology. We know that this is also a common problem with aging. As Dr. Gallagher mentioned earlier, vascular pathology happens, and it accounts for cognitive decline as well. We know that in people with Alzheimer's disease, there is strong evidence of large vessel compromise, cholesterol-related plaques that build up in these vessels. There's also stiffening of the vessels themselves that can be seen under a microscope. We have shown, using very interesting new technique called 4D flow, that the vessels in the AD spectrum are indeed very much stiffer. And we've also shown that the transit time of the cardiac pulse wave from the arterial side to the venous side is much faster in patients with symptomatic AD. And there's also, so that means that the brain is not getting quality perfusion. The blood is going right through, maybe putting quite a bit of stress on the arterioles and capillaries as the blood races through the brain. And that would cause tortuosities in those small vessels and micro hemorrhages and things of that nature that would exacerbate any illness. There's also a great deal of new evidence, exciting evidence in the field, we're not doing it here, that the brain has its own glymphatic system or clearance system, and that some of these pathologies like amyloid plaques and tau-related pathology can be cleared from the brain using this garbage network, garbage clearing network. And we think, according to the literature, that network relies on an intact vascular pathology, a pulsating vascular pathology that helps drive some of the clearance outside of those vessel cell walls. So let me just show you a little bit of what we're talking about when we measure this vascular pathology. This technique was developed here at University of Wisconsin by Oliver Wieben, together with Kevin Johnson and Pat Tursky in radiology and med physics. And you not only get a very quick angiogram of the brain, what's more informative to us is the dynamic 4D information that you can get from this. And we're showing a large vessel here. You can see the blood as it's pulsing through, and we can track the cardiac waveform here. We can get a sense of how much the vessels are expanding and how occluded the vessel is and whether there's shear forces acting in any part of the brain. So we've been applying this, and to give you a sense of the pulsatility or vessel stiffness, here's something where you see the large vessels in the brain of an AD patient on top there, and a patient with MCI and a healthy control on bottom. And this is very much what we're seeing in groups and in individual cases. So very exciting. We've also shown that the level of flow and vessel health is related to the amyloid levels in one's spinal fluid. And so this is really intriguing to us. It says to us that there is an intercorrelation here between the vascular side and the classic AD pathology side. And whether these things interact in a more fundamental way requires longitudinal study from people who are asymptomatic and following them to the symptomatic phase. And that's what we're doing with the study that we have now. I think I should probably stop there and take any questions. I will say that the study that we're going to do is involving people from the Wisconsin Registry for Alzheimer's Prevention. We will be doing these advanced 4D flow techniques and also looking at plaques and tangles in their brain. These are people we've been following since roughly age 54, and now the mean age is approximately 65. So we have a good sense of their cognitive trajectories, and hopefully we'll have an understanding soon of their neurovascular and amyloid pathology as well. So I'll stop there, and I'm going to just race to my acknowledgement slide. I knew I prepared too much. Here we go. All right. Any questions? Yeah. Great question. Do we disclose the results? We have not been disclosing results. We're following closely a national study that is to see if there's any adverse problems with that. It will take a lot of counseling and advising these individuals that having the pathology doesn't mean that you're going to get the symptoms. And what do we tell them to do about that pathology? Those are things we just don't know. I think it's too new. But right now we are not disclosing, but that may change as more information comes in. It's an important one. Yes, Chuck?
Great images.
Thanks.
The,
Thanks for your help with all that.
we have several models of accelerated vascular disease. I wonder when you look at those models, what their amyloid, if you have looked at those models, for instance, in diabetics or patients with renal failure, transplant population have known accelerated vascular disease. Have you looked at those patients for their amyloid and plaque images?
We haven't. That would be a wonderful thing to do, and also just looking at the brain on the 4D flow vascular side to see if the dysfunction seen in their diseased organ also translates to the brain. That would be very interesting to do.
I have a question.
Yep.
What do we know about the status of the blood-brain barrier in AD? Is it normal?
What's the status of the blood-brain barrier in AD? It is not normal. We don't have great ways of measuring that with imaging now. You have to use contrast, and it's a very noisy measurement. But the studies that have been done show that it is abnormal, especially in that medial temporal lobe area. Yes? The medications are just neurotransmitter boosters right now. They don't alter the fundamental biology. There are several clinical trials that are underway, and some of them have shown some degree of promise, although most have been negative at this point. Some of the slides I skipped over would have shown there may be some lifestyle things that we can do. For example, people with diabetes or insulin dysregulation, not full diabetes, they tend to have more amyloid in their brains and more vascular pathology in their head. So treating that may be a good thing to do. There was another study where we showed that people with less sufficient sleep, there's a correlation there with more amyloid in the brain. And there's another study showing that people who don't exercise, there's a correlation between amount of exercise and physical activity and amyloid and tau in the brain. So there's potentially some modifiable things we can tell our patients. Right now, those are just correlational things, and there's trials that are starting to happen now on those kinds of things to see if they'll stop the progression in the preclinical framework. There was the question is what's the correlation between herpes and infectious disease such as that and Alzheimer's disease. There was a great study that got some press about 6 months ago showing that there can be infections like that inside of these amyloid plaques, and perhaps their job and the reason they exist is to sequester pathogens that get into the brain. So there are investigations, some of these are happening at Harvard, where they apply these kinds of viruses and other pathogens in mice, and they're showing that indeed that is happening. Whether that's the case in humans, we don't know, but that is a question that's very much being addressed in the field. We're not doing anything on that here, though. Thank you all.